Welcome to this Step 3 clinical knowledge review on trauma management test-taking strategies, brought to you by Roadmap to Residency. Trauma questions look intimidating, but they reward a calm, ordered approach more than memorization. Today, we will break down how the boards build trauma stems and how to pick the right next step quickly and confidently. Our goal is not to reteach all of trauma surgery. It is to train your eye to spot the pattern and apply a rule. Before or alongside this video, review the trauma and surgery sections of your major review books and a good question bank so the foundation is already there. Here is our plan. First, we will learn to recognize the high-yield question stems for trauma, starting with the primary survey and the evaluation of shock. Then we will apply test-taking strategies to the focused assessment with sonography in trauma, to trauma imaging, and to the decisions around calling a consultant and transferring a patient. Finally, we will master the next best step format for head trauma and intracranial bleeding. Throughout, keep your review books and question bank close, because this video teaches you how to use that knowledge on exam day, not how to replace it. Our first strategy is the most powerful one in all of trauma. The primary survey always comes first. The advanced trauma life support sequence is airway, breathing, circulation, disability, and exposure, and you work it in that exact order. The single most common trap on the boards is a stem that describes a dramatic injury, like a mangled leg or a tender belly, while quietly mentioning that the patient cannot protect the airway. The right answer secures the airway because airway comes before everything else. When a stem lists several problems, map each finding to its letter, then act on the earliest letter that is abnormal. Attention pneumothorax is a breathing problem, so it is fixed before you chase bleeding. Hemorrhage is a circulation problem. If you simply refuse to skip ahead, you will get these questions right almost every time. Strategy 2 is reading the shock picture, because trauma stems love to test whether you can tell where the problem is. A patient who is hypotensive and tachycardic with cool, pale skin is in hemorrhagic shock until proven otherwise, and your job is to find where the blood is hiding: the chest, the abdomen, the pelvis, the thighs, or the floor. The first move is volume and blood, then control the source. But watch for the twist where blood pressure does not improve with fluids. If the neck veins are full and one side has no breath sounds, think tension pneumothorax. If the neck veins are full and the heart sounds are muffled, think cardiac tamponade. Full neck veins with low blood pressure should pull your answer away from giving more fluid and toward decompressing the chest. Now let us train on stem recognition. There are 3 patterns you will see again and again. The first is the unstable patient with blunt abdominal trauma whose pressure will not hold despite fluids and whose sonography shows free fluid in the belly. That patient goes straight to the operating room, not to the scanner. The second is the stable patient with the same blunt trauma but normal vital signs. Because they are stable, they can tolerate the scanner, so computed tomography of the abdomen and pelvis is the answer. The third is the head injury with loss of consciousness, vomiting, severe headache, or a focal neurologic finding, where the answer is a non-contrast computed tomography of the head. The word stable or unstable is the hinge on which most of these questions turn, so circle it every time. Let us work through our first practice question. A 30-year-old man arrives after a high-speed motor vehicle collision. His airway is patent and his breath sounds are equal, so airway and breathing are fine. His blood pressure is low and his heart rate is high, and after 2 liters of fluid he improves only briefly. A focused assessment with sonography in trauma shows free fluid in the abdomen. The question asks for the most appropriate next step. Take a moment to notice the 2 facts that matter most. He is unstable and his sonography is positive. Think about what those 2 facts force you to do before you look at the choices. Let us break this down step by step. Step 1, spot the pattern. He has hypertension that responds only briefly to fluids, plus free fluid in the abdomen on sonography. That is a hemodynamically unstable patient with bleeding inside the belly, and the instability is the loudest signal in the stem. Step 2, apply the rule. An unstable patient with a positive sonography goes to the operating room, so the answer is exploratory laparotomy, choice B. Surgery finds and stops the bleeding without delay. Step 3, eliminate the wrong answers. Choice A, the scanner, is wrong because an unstable patient should never leave for prolonged imaging. Choice C, peritoneal lavage, is outdated once the sonography is already positive. Choice D simply wastes time he does not have. The answer is B. Here is our second practice question. A 20-year-old man is struck on the side of the head with a baseball bat. He briefly loses consciousness, then wakes and feels completely normal for about an hour. He is now brought in confused and increasingly drowsy with a fixed and dilated pupil on the right. His blood pressure is rising while his heart rate is falling. The question asks for the most appropriate next step in management. As you read the choices, hold on to 3 details: the blow to the temple, the period where he felt fine, and the blown pupil with the rising pressure and falling heart rate. Those details are pointing you toward one specific picture. Let us work through this answer. First, read the question carefully. A blow to the temple, a brief loss of consciousness, a lucid interval where he felt normal, then rapid decline with a blown pupil is the textbook story of an epidural hematoma. The fixed, dilated pupil, the rising blood pressure, and the falling heart rate together tell you pressure inside the skull is climbing fast. Now, why does the head scan win? Because the very next step in acute head trauma is always to confirm the bleed with a non-contrast computed tomography of the head, which classically shows a lens-shaped collection that does not cross the suture lines. Magnetic resonance imaging is too slow for an emergency. A lumbar puncture is dangerous when pressure inside the skull is rising. Sending him home would be fatal. The answer is choice A. Let us talk about consultation and transfer because the boards quietly test your judgment here. Know who to call and when. Any intracranial bleed needs neurosurgery. Free fluid with instability needs general or trauma surgery. An open fracture or a limb with no pulse needs orthopedics and vascular surgery. The unbreakable rule is that calling for help never delays a life-saving step in the primary survey, so you stabilize first and then consult. Transfer becomes the answer when your hospital simply cannot provide the service the patient needs, such as a bleed in the brain at a hospital with no neurosurgeon. When you transfer, stabilize the patient as much as possible first, and never delay an emergent operation that the receiving center could do sooner. Definitive care that cannot wait always beats moving the patient for its own sake. Here is our third practice question. A 60-year-old woman falls and strikes her head. At a small rural hospital, a non-contrast computed tomography of the head shows a crescent-shaped collection of blood along the surface of the brain. She is drowsy, but her airway, breathing, and circulation are all stable. The catch is that this hospital has no neurosurgeon and none is available on call. The question asks for the most appropriate next step. As you weigh the choices, notice 2 things. The shape of the bleed and her age tell you what it is, and the missing neurosurgeon tells you what this hospital can and cannot do for her. Let us break down this answer. The crescent-shaped bleed along the surface of the brain in an older patient after a fall is a subdural hematoma. She is stable right now, but a subdural can expand, and either way, it needs a neurosurgeon to evaluate it. The decisive fact in the STEM is that this hospital cannot provide neurosurgery, so the answer is to stabilize and transfer to a center with neurosurgery, choice B. Observing her at a hospital that cannot operate risks a fatal delay. Repeating the scan in 12 hours wastes time while the bleed may grow. Starting anti-seizure medication and sending her home ignores the actual surgical problem. When the service the patient needs is unavailable, stabilize and transfer. The answer is B. Here is a high-yield test-taking pearl on head trauma bleeds. Learn to separate epidural from subdural by shape and story. An epidural bleed is arterial, lens-shaped, does not cross the suture lines, and gives that classic lucid interval after a temple injury, usually in a younger patient. A subdural bleed is venous, crescent-shaped, crosses the suture lines, and tends to show up after a fall in an older patient or in someone on blood thinners. Match the shape to the story and the diagnosis appears on its own. 2 reflexes will carry you through the management questions. First, the non-contrast computed tomography of the head is always the first imaging study in acute head trauma. Second, any sign of rising pressure inside the skull, like a blown pupil, a rising blood pressure with a falling heart rate, or a dropping level of consciousness, means you involve neurosurgery immediately. That wraps up our trauma management test-taking strategies for Step 3. Remember the through line. Work the primary survey in order and never skip ahead. Let the words stable and unstable steer your imaging, and call for help or transfer the moment the patient needs a service you cannot provide. For deeper study, review the trauma and surgery chapters in your major review books and your question bank, and drill the primary survey, the sonography assessment, and the management of intracranial bleeding. If this helped you, please like and subscribe so more students can find it. And when you are ready for one-on-one guidance, visit roadmaptoresidency.com to work with our expert tutors and residency advisors. Good luck on your exam, and we will see you in the next video.